All you have to do is push. It times out over time. Good morning. Good morning. Welcome to our first medical education grand rounds of the coming year. We have an exciting year planned. Next month, we're actually flipping the time, and we're going to have Mr. Alan Auld do an evening medical education grand rounds. I know that those of you who are MASH fans in the audience will be very excited to participate. That one, though, you have to RSVP because it's a ticketed event. And then we have some other exciting grand rounds throughout the year. Those are posted on our website. Our students are going to be sponsoring a grand rounds with Dr. Lisa Meeks, who will speak about trainees with disabilities. We're very excited about that opportunity. But as the first one of the year, this becomes part of a tradition that we've had going since the inception of the school. Every other year, we invite a group from the Uniformed Services Medical School, led by Dr. Joseph Lopriato. Joe, want to raise your hand? Joe is a pediatrician. He's the Associate Dean of SIM at Uniformed Services, U.S. Navy retired, and he's led this group every other year who come out and do a great job with an immersive experience in faculty development. So he and his team will be here this week visiting with us, and you've gotten several invitations for the various events. They're also posted on our board near the elevators, so please do avail yourselves of the opportunity. It's a great pleasure for me to introduce Dr. Courtney Judd. Dr. Judd is a lieutenant colonel in the U.S. Air Force and an assistant professor of pediatrics at the Uniformed Services University of the Health Sciences. She's a local person. She grew up in Bethlehem, Pennsylvania, got her bachelor's degree from William and Mary and her MD from University of Virginia. She did her residency in pediatrics in San Antonio at the Uniformed Services Health Education Consortium, where she served an additional year as chief resident upon graduation from the program. She was then stationed at Hickam Air Force Base, which is in Hawaii, not too bad, for 3 years prior to completing a 2-year fellowship in general academic pediatrics and also receiving a master's of public health at the University of South Florida. She then returned to San Antonio as a clinical educator and spent 3 years as the associate program director for the pediatric residency program. During that time, she was deployed to Afghanistan for 7 months in support of Operation Enduring Freedom. She has participated in multiple humanitarian missions throughout her military service, including trips to Honduras, the Philippines, and America Samoa. She has been an active member of the American Academy of Pediatrics, the Academic Pediatric Association, and the Association of Pediatric Program Directors. She joined the Pediatric Education section at the Uniformed Services Medical School in 2016 and was recently named the Director of Pediatric Medical Education. She continues to pursue training in the field of health professions education. She's actively getting her PhD, correct, Courtney? And is active in clinical teaching, hospitalist medicine, and faculty development. So please join me in giving a welcome to Dr. Judd.
Thank you all so much. Good morning and welcome. I'm so glad so many of you were able to make it out this early in the morning, especially on such a cold morning. I'm glad fall's finally here. Being from the Northeast and having lived in places like Texas and Hawaii and Florida, it's been rough because it's been so warm. So I want to just let you all know how excited I am to be here. It's been about 2 years since I was here last time. I came with the roadshow, this faculty development crew, It was my first time being with them, and it was also a time to see this new medical school that had just developed and hadn't even graduated its first class yet. So now I feel like coming here 2 years later, I have a lot more professional development of my own under my belt, and the school has just grown so much and had so much success, so it's neat to see that interval change. I'm also excited to be able to talk with you about this topic, the hidden curriculum. It's a relatively new area of interest for me, but something that I've been excited to dive into. I'm going to be working with a colleague back at the Uniformed Services on a project looking at some qualitative research on this coming here in the future. But I think it speaks a lot to your leadership that they're putting forth this topic as something to have a discussion about. And I really admire that and think you all are in good hands with people that are willing to talk about this and bring it to light. So I wanted to show you a little bit about where we're going to head over the course of the next 45 minutes or so. I wanted to do some introductions of our team. We had a good head start there, but I'll go through each person that's on the team that we started yesterday and will be here through tomorrow evening doing our faculty development. We'll talk about what the hidden curriculum is, what exactly that means, and then I want to give you some background that I found was kind of one of the most exciting parts about this topic for me was how it first got associated with medical education. And then I have some examples. I have a video clip or a few that we can watch depending on our time, and we'll analyze that a little bit. And then finally, I want to make sure that we have time for some practical applications so that we can have a bit of a discussion about how we can incorporate a new awareness or a deeper awareness of this subject into our daily lives. So you heard a little bit about me. I am a local girl relatively, so it's kind of exciting to be back in this area, both for work as well as for this trip itself. The first person that I wanted to mention was Dr. Joseph Lopriato. You had seen his hand go up before, but we could see if I'll put it up one more time. So Dr. Lopriato is definitely a mentor of mine. He found me when I was in my general academic pediatric fellowship. He was figuring out where all of the military folks were who were scattered in these civilian programs, and kind of gathered us in under his wing, has been a coach, a sponsor, has played multiple different roles for us. So it's really exciting that he trusts me enough to bring me along on these trips. But he also is a local man. So he grew up in Newark and is an Italian. So he's that typical Italian from New Jersey. You got to watch him, just if you know what I mean. Next, we have Dr. Greg Blaschke, so sitting next to Dr. Lopriato, and he is also a retired Navy pediatrician, is trained in academic pediatrics, does some developmental behavioral pediatrics, but is currently the division head of general pediatrics at OHSU, and he is also a definite role model of mine and mentor, somebody who it's great to have been connected with through this program. When he's not fighting off the anti-vaxxers out in the Pacific Northwest, he does a lot of these road shows that he's traveled to multiple places. They've tried to count up how many they've been to, and I don't think they even can over the past 16 years. Last but not least, we have our black sheep of the program here. It's Dr. Josh Hartzell. So he is over here on my far left, your far right, and I call him the black sheep only because he's our token internist on the crew. So he came to balance out the team. And he has developed a lot of different faculty development sessions. He's kind of doing that as his full-time job as the assistant dean for faculty development at USU. So brings a lot of experience to the team. So now that we've gotten through some introductions, I just wanted to make sure that we go through and develop a shared understanding about what the hidden curriculum is. How many people have even heard that term before? Okay, and I thought we'd have an audience where a lot of people had. Some of the more junior people may not have heard it, or may not have heard it spoken about, but I do believe that it gets mentioned at orientation from what I hear. Basically, the hidden curriculum is the part of our education that's conveyed beyond the explicit, beyond the expressed, the verbal, beyond what's written in our curriculum. And the people that I'll be mentioning a lot as kind of the folks that first brought this into the medical education realm talked about it at times as being a latent curriculum. I personally don't agree exactly with that term because I feel like it evokes an image of a dormancy, and there's definitely not a dormancy. When you talk more about the hidden curriculum, you realize it's a very active part of our education and our becoming physicians and health professionals. But I do agree with the rest of their definition of it. It talked about it's more concerned with replicating the culture of medicine than with the teaching of knowledge and techniques. And as I kind of reflected on my career and different times where I think this has really come into play, one big one that stood out as an example to me is that when I was first starting as a medical student, I was ecstatic to be having my white coat ceremony. I was so excited about it. I thought that it was the neatest thing, that here was this symbolic gesture where I was being given my white coat. I was being welcomed into this community and as a part of it. And I just thought, I love ritual, I love tradition. This was so neat. So I was, at the time, I had just developed a relationship with a mentor of mine who was a pediatrician, but also had a PhD in religious ethics. And she just thought about things in a totally different way, had a much deeper understanding of a lot of things than I did for sure at that time. And I remember her saying to me, "I hate that white coat ceremony." And I was shocked. I thought, what? How could she hate that? That's who we are as physicians, and it's this kind of token ceremony. And she told me that she hated it because she felt like it put up a barrier between us and the patients. And when I reflect back on that, I thought, wow, that's what it was speaking to her. She was worried about that barrier that we might be putting up there. I hadn't even thought about that. And what that brings up for me is the idea of kind of a relativism in the hidden curriculum. So it depends on your experiences and kind of where you are in your life and what you've witnessed. I still firmly believe in the white coat ceremony, and I love it because I know what it means to me. But it helps me to understand that, okay, there was a different viewpoint out there. Right. So now that I have given you a little bit of an example of the hidden curriculum in my life, I wanted to see what you all thought about my introductions. So I tried to throw some nuggets in there that we can maybe dissect here a little bit together. And I didn't know how willing you'd all be to call me out right away. So I thought if you can turn to a neighbor and pick out one or two things from my introductions that I mentioned, try to see if there were any elements of the hidden curriculum in what I spoke about with my team and my colleagues. And I'll give you about a minute to do that, and then I'll ask you for some answers. Okay, it sounds like you all have a lot to say, which makes me excited to hear. So let's start with my introduction of Dr. Lopriato. So what stood out to you in that? Yes.
So you chose to mention that he's a paisan. And he is indeed. We grew up a couple of blocks from each other, and then we went to the same medical school, so he's also a friend. But I noticed that instantly. Being of that same ethnicity, I noticed it.
Right, so I pointed out that he was an Italian, a paisano, as you say, from New Jersey. And what did I imply about that? He's not necessarily on the up and up, exactly. That's putting it gently, right? Did I imply that Dr. Lopriato has connections to the mob? Maybe. But I left that out there, right? I really talked about a different side of him that might exist, but doesn't. I promise you, I assure you. How about anything that stood out about my introduction with Dr. Blaschke? Yes.
So I'm also a pediatrician, but we did hear the vaxxers, I guess is that the term you use? So, that could be taken depending on where you're
Absolutely. Thank you for bringing that up. I'm glad that stood out to somebody as a negative connotation. So that term anti-vaxxers kind of gets thrown out there, and it really had no business in my introduction of Dr. Blaschke. He's one of the most open-minded people I know. But it's nothing I would ever say for sure in this setting, and very, very limited in private. I firmly believe in vaccines and in their safety and their importance, and I will advocate for them at every step of the way. But I would not intentionally ever try to put that viewpoint out there that I was already disparaging them, kind of setting them off as separate. It makes a lot of assumptions, right, about who those people are, that it's us and them, that it's this distinction. It also made an assumption about who you all are as the audience, that it was okay to say that, and that I was assuming that you all agreed with me and thought of them as different. So thank you very much. That's absolutely one of my nuggets. And then how about with Dr. Hartzell? Oh boy, what did I do to Dr. Hartzell? Yes, sir.
So in a room where there aren't many minorities, the English language always uses black as something that's bad. You describe it as black sheep.
Absolutely.
And I linguistically take offense to that. Because if you go to sub-Saharan Africa, the person who's the outsider is not called black sheep.
Right, and I do apologize if there was any offense at the get-go. I meant to bring these up as ways that you can see some of these things coming up, and for many of us, in some casual ways. For some of us, it's just a turn of phrase that we don't even think about the roots of it or what impact it has on anyone else. But I absolutely appreciate your viewpoint, sir, and I appreciate that you brought that up, because the connotation of it is that they're different or other. Sometimes the connotation could be that they're less than, and by no means would I ever think that about my colleague or say that about my colleague. And I also don't want to give the implication that it is at any way related to skin color or anything like that. So absolutely, that was something that was thrown in there intentionally, but I do want to make sure the debrief is complete and that it was put out there as an example of sometimes how those things can get tossed around and we don't think about the meaning or the impact on other people. Okay, anything else that stood out to folks? I said the token internist, right. And then all of that can kind of set him as somehow a different part of partitioning him off, right? Right. Okay, well, we will keep moving along then. So the background for the hidden curriculum and how it started to interweave into the medical education world starts with a couple of men named Dr. Hafferty and Dr. Franks. And when I first discovered this article, it's a really interesting one. There's a lot within it. They talk all about kind of the culture of the time and this movement in ethics and how that related to medicine. And what they were really putting forth was a way forward to kind of get through some of the crises in the medical culture that were occurring kind of the late 80s, early 90s. So there were all these problems being highlighted, things like the breakdown of the physician-patient relationship, a loss of advocacy in the healthcare world, advancing technology that was creating some issues of its own, as well as seeing the patient as the consumer. So all of these things were kind of coming to a head at that time. And there was this big movement in medical training to try to figure out how to do ethics education. And it's shocking to me to look back at the time and think that there wasn't formal ethics training in medical training, or wasn't as well developed as it is now. But the overall kind of standard movement was towards this formal ethics training, making it a part of our curriculum, and making sure that it was overt and kind of concrete, that there were times set aside for it. But what Dr. Hafferty and Dr. Franks were recognizing was that the hidden curriculum was probably far more important in the development of our identities as physicians, as nurses, as technicians in medicine, and that probably much of that was taught inadvertently, much as the hidden curriculum implies. So they wanted to focus more on the idea of everyday life and how we incorporate ethics into that, as opposed to this concrete rigid formal training in ethics. What they saw it as was a moral enculturation, that as we go through medical training, we are learning how to be a professional. We're getting, some people have called it socialization or professionalization. That's occurring just almost by osmosis as we go through our daily experiences. And it is not so much based on the knowledge and skills that we're acquiring, but really of how we're developing ourselves into the character of being a physician or a nurse or a technician. And there have been thousands of studies on the hidden curriculum in that intervening time, so over the past 23 or so years. One of the ones that a mentor of mine pointed out was this one. So a few researchers got together and they were looking at issues of professionalism. What they really wanted to study was what is going on in the mind of a medical student as they're confronted with ethical issues, and how do they work through that? So they did a qualitative project where they brought in medical students. They did a total of 18 student interviews. They had the students watch these video clips that were 1 to 2 minutes long. And each video presented a routine clinical scenario and ended with a decision point. So the medical student had to decide, were they going to continue to hide lab results from a patient because they weren't the primary team member? Were they going to go out and have a beer with the rest of the team while their patient was really needing somebody to talk to because their shift was over? And a few different things like that. So the researchers looked at how these students thought through what they were going to do. They looked at what decision they made and what alternatives they considered, and all the factors that went into those decisions. And what they came up with was a little bit of a broadening of the definition of the hidden curriculum, but also some nuance within that. They talked about the avowed curriculum, and they said that the avowed curriculum are those things that all of us would be willing to shout from the rooftops. This is a part of our profession. This is absolutely what we stand for. Things like honesty, like a commitment to patient safety, or commitment to putting the patient first. And those were oftentimes mentioned in the clinical or the critical decision-making of these ethical dilemmas. Then they mentioned the unavowed curriculum, and that's what correlated the most with what we traditionally think of as the hidden curriculum. So these are the things that don't get explicitly discussed. They're not overtly endorsed, but they're expected. So it might be unintended, might be intended, it's tough to say, but they were reinforced overall. And the things that they related to this were, they realized the students sometimes felt an allegiance to their team or to their to the patient sometimes, but it typically referred to the team, or an obedience, a deference to them. So things like that we wouldn't necessarily say, yeah, when we're defining our profession, we want the junior folks to have deference to us, but that does get reinforced over time. And then they also brought to light what they called the disavowed curriculum. So in some of those scenarios, the students mentioned, well, I am worried about my evaluation at the end of this rotation. And if I work against the team and what they're saying I should do, how's that going to affect my evaluation or my grade? And some of them even mentioned things like, well, I don't know, I might feel really anxious, or that might give me some emotional turmoil. And so that was a different way of relating it to oneself and the implications on oneself, but more in an internal way. But they felt that this was disavowed, in that if it were to come to the light, to the surface in our day-to-day lives, people would say, nope, that's not consistent with what we think it is to be a physician, because we believe in altruism and we believe in putting others first and putting the patient first. So they really helped to kind of discern some of these differences in how we look at what's being taught and what's being given and received in medical education. So specifically, when we think about what it is that's learned through the hidden curriculum, I found that pretty much all of it relates back in some way to professionalism. And it often does support what we're trying to teach, our avowed or our overt or our formal curriculum, and what we believe we are as professionals. So I don't want that point to be missed, that much of the hidden curriculum is going to be a positive thing. It's going to be a student who witnesses their attending sit down and relate to a patient while they're crying or dealing with a difficult diagnosis and giving them the extra attention that they do need. Or it's going to be somebody witnessing a resident who walks a patient to radiology because they have that extra minute and they know that that patient would get lost in the hospital otherwise. So it can be very positive things. But we tend to focus more on the ways where it contradicts what we want to be the ultimate goal. And Dr. Hafferty and Dr. Franks also mentioned they made a big distinction between us learning about ethics as tools, which is what they saw the formal curriculum doing. So using the ethical principles and figuring out when they would apply and how you would apply those two different dilemmas, but those being distinct from the ethics as identity. So who we are as a profession, which is, again, much more absorbed through that hidden curriculum and the time we spend with each other learning the culture. And then I want to come back to this point that was brought up early on in our analysis of my introduction. So perception is a big part of understanding the hidden curriculum. We're all going to come at each scenario we're faced with a very different background. So we need to pay attention to the level of diversity that's out there in our culture, our local communities, as well as the larger communities. And then especially paying attention to the stage of training that people are at. So the earliest trainees being probably the most vulnerable to these nonverbal inputs. Okay, so I want us to spend a little bit of time looking through and watching this video clip. I'm picking on pediatrics here first, since I am a pediatrician. I felt like that would be okay. And these videos were developed from a crew at the Thomas Jefferson Medical School. But they talk about professionalism in general. But what I want you to do is focus on this video and what's happening through the lens of the hidden curriculum. There is a pretty interesting interaction in terms of a consent process. That part we could spend hours on alone. Don't focus as much on that, but focus more. There's a resident and a medical student, and I want you to watch through their interactions.
Good presentation, Rebecca. I agree with you. A child of this age with fever, hunger, before showing back stiffness, probably consumers know. We should also start antibiotics ASAP.
I've never seen a child so sick like this before. I'm really excited that we got to see her together, and I'm really glad I get to assist you with the LP. I got to see a couple of spinal taps last month in my medical clerkship, and they even let me do a couple of them on the models there in Clinical Skills Center. This one's just so much different.
Well, you know, it's really not that hard. I actually think it's more difficult on the models than on a real child. It's easier to find landmarks on a child. You know, I think you should do this one. She is your patient. She's got great landmarks. I'll help you hold it.
Well, I don't think so. I really don't feel comfortable doing one yet, especially on a child.
Remember, see one, do one, teach one, okay? This is a great case for you to be on your about. We'll go with you.
I'm glad your daughter is more comfortable now. She seems to have quieted down. We're concerned that she may have an infection somewhere. So we're going to test her blood and her urine for any possible signs of that. Another potential site is the lining of her brain and her spinal cord for infection, which could be meningitis. So we need your consent to put a needle into her spinal canal and extract some of that fluid so we can test it. Now, it's not painful. We're going to numb the skin around the area where the needle goes in. There are some risks, however. There's a possibility of infection, bleeding, very rarely paralysis. And although these risks are unlikely, we are obligated to inform you of them before you sign a consent form. Okay? So why don't you take a look at that? Here's your pen. I have my consent. I trust this hospital. So do what you do. Now, as I'm sure you saw in the consent form, student Dr. Johnson is the one who's actually going to be performing the procedure.
So does that seem like a realistic possibility of the way that a consent process could go? I'd like to think not, but how about the interaction between the resident and the medical student? Does that seem realistic? Like it could happen? Okay. I want to see if we can get a few different people to weigh in. What was the overall message that you took away from that interaction between the resident and the medical student? Yes.
Well, it's clear that the medical student wasn't comfortable having that be the reverse experience during the chat. The resident was kind of aggressive and certain views such having her go forward despite not being ready to do so.
Okay, excellent. So it was clear that the medical student wasn't comfortable, and I heard you mention the resident was being aggressive with insisting on that. Now, was the behavior overtly aggressive? It was. And this is exactly why we talk about this, because so the behavior wasn't, but the insistence on her doing that procedure and the assumption could be perceived as aggressive. What is? So did you say he was being encouraging? Okay.
That was my interpretation. I mean, he may have had a weird affect about it, but
We won't comment on his social skills.
yeah, but like, there was a student who had done models, had done taps on adults, patients, who's really invested in the care of this patient, and I'm saying this as a pediatrician. I think this senior resident was saying, look, this is an opportunity for you to develop a skill that wouldn't happen otherwise. Like, I think it was actually trying to be encouraging. Again, putting aside his affect and whatever else is going on with that. But like, it seemed like he was trying to be supporting and trying to push the student to go to an uncomfortable place to see where they could to learn.
Great. So we got a lot of students. She had mentioned how many of these procedures she had done. And the first time I looked through this video, I definitely thought, wow, she's priming him. She really wants to do this LP. And I also took away that, okay, he was really just giving her that leverage, and he was giving her a little bit of autonomy, like, you're going to be doing this, and I'm going to be there to support you. So there's also the perspective that he was being supportive. Okay, was there another hand?
Well, looking at her face after he said, you're going to do this, there's no way that I would want her to do it. Number two,
We wouldn't want her to do it.
being
Okay.
a student who was showing what she knew, who was invested in the patient, although they didn't even talk about the patient, it was only about the case and how exciting it was to do this lumbar puncture, which is another problem. But many students are enthused and excited and want to share what they know to a resident. That doesn't necessarily mean that you shouldn't also listen to the student. And I feel like there is a time and a place, and this baby's sick. This baby needs this lumbar puncture. Should be getting antibiotics right now while they're figuring it out. And, she's going to be doing a procedure that clearly, looking on her face, she was extremely uncomfortable doing. And yes, she's going to have to do one eventually, but I do think it's important to listen to your student and, look at their face and figure it out from that if you don't want to listen. So I took it a very different way.
Okay, so important to look at the student, to know that they might be trying to share their viewpoints with you and what experience they have had to date, but it doesn't necessarily mean they're ready to make that next leap. So, great. Yes?
I think it's a very delicate balance. I think there are many different types of students, and to figure out, you have to know your students a little bit more. Some are just very shy and maybe very good and not forthcoming, and they need a little nudging around. And others may be telling the truth and they need more confidence building before they do. So it's very difficult to say just by this clip that I think what upset me most is the consent process.
I know, and that's why I said we could absolutely talk and debrief about that for a long time, because that was just horrendous. But yes, so the point overall in terms of the hidden curriculum is that we do need to know those varying perspectives, because there are some students that may just approach things in a more quiet, more reserved way, but might be willing to kind of jump in there and do that procedure. So the important thing is knowing where they're at and responding to what's going on. And making sure that you clarify, because who here feels like the resident and the student had the same agenda? Does anybody feel it? Who here feels like they had a different agenda? Each individually. Okay, I definitely agree with that personally. But I remember one of the things too that crossed my mind as I was watching that video the first time or two was that, you know, if you think about, we were talking about this patient as just a case and just a procedure as opposed to the patient side of it, which is a whole issue in and of itself, what we're saying about that case instead of that patient, instead of personalizing it. But it also is something that as a resident, I wanted the chance to do LPs. I needed them, I wanted to practice them, I needed them for my proficiency. So for this resident to be willing to give one up for a student showed a lot of respect for that student and a commitment to the education. So I thought that was another thing that stood out, but I couldn't shake that feeling that that student just was not feeling heard and was feeling overwhelmed. Yes.
Like the resident said, look, see one, do one, teach one.
Yes.
Telling this is the way it is around here. You know, that's the rule. That's the law. Live with it.
Right, so see one, do one, teach one, as imparting a rule or a law. That's how it's done around here. And how many of you have heard that phrase? Right, I can't count how many times I've heard it throughout my career. But
honest, I use that for ultrasounds.
and
I tell my students that, you know, because unless they put their hand on the book, they're never going to learn how to do an ultrasound.
right,
And the only way to learn is to do it.
right, and I.
This card, ultrasound, you can't screw up too much, but.
So the risks of the situation come into play. So you're saying definitely you've had to employ that, and I think in an overall perspective, it really relates to the context, right? So in this situation where the student was saying, but I'm not ready, and then here's see one, do one, teach one, it's like, if you're not ready, you're incompetent, is kind of what this was implying. Whereas if you're using it in a different situation, the stakes aren't as high, the student's not scared about all those things she just heard in the consent process and what she's gonna do to that baby. There's a different connotation when the risks are lower or it's a different situation. Yes?
So there's also something that's implied here that may not be able to be generalized at every hospital center that has this situation, and that is that there's no resident with the student, there's no attending to be found. How confident is the resident as teacher and supervisor in this setting? You know, and would this be different if it were attending to student or attending to resident? You know, I think that there are very different cultures in a tiered academic medical center than in a community hospital, and the expectation of the family is very different. I trust
Right.
this hospital. Well, you know, maybe the Mecca Ivory Tower Academic Medical Center, you know, has a great reputation, but you know, does that really filter down to the trainee at that hospital, or is that just the reputation? So the family has this bias that, you know, they might have more faith than those learners that are there. You just kind of can't unsupervise those.
Right. There's a lot of goodness in what you said in terms of picking this apart. But basically that resident med student relationship being different. Who knows if the resident feels totally uncomfortable doing the procedure himself and thought, well, she has a better shot at it than I do. We don't know that going in. But then also, right, that implicit, the father trusts the hospital, but does he trust this individual? And is he feeling pressured to kind of cave to that because of the reputation and he doesn't feel comfortable asking questions? Okay, yes.
Just a comment, fear can be a huge inhibitor of learning, and there was a bit of a missed opportunity for the residents not really picking up on that, and while many times, myself included, we sort of pushed through, and that's maybe why some thought he was a bit aggressive, but to really pause for a second, see where can we shine the light on decreasing our fear and making a learning opportunity for our students.
Great. So, and that kind of hits on these points about what could have changed and made this a little bit better. So could he have said, look, I really think that you're ready for this. I think everything you've told me shows that you're ready. Why don't we go through it briefly, talking through what the procedure is going to be. We do have to be pretty quick about this because it's an emergent procedure, but let me talk you through it. I think, you know, if you're going to start somewhere, this is a great patient for it, and this is the reason why, but actually being more explicit with that could have helped and could have been a great learning opportunity for both of them, for the resident as a leadership opportunity and for the medical student to actually have some of the procedural growth there and confidence as well. All right, I'm going to move along just to stay on time. I want to make sure that we can finish up here and get you all to your next places. So I had a couple of other videos, but it's kind of similar process, and I really appreciate all that input there. So when we think about then turning to the practical application, trying to seek to bring to light this hidden curriculum, I thought two questions kind of came to mind. So how do we ensure that everything we teach is intended? And then you'll probably kind of guess at my answer to that one based on the second question. How do we account for unintended messages in what we teach? And these are kind of more rhetorical, meant to just get you thinking about this. I wanted to give you a little bit of insight based on what Dr. Hafferty and Dr. Franks mentioned over 20 years ago in their paper, the recommendations that they had. And then I want us to talk through just a couple of ways that we think that we can apply this. So what they mentioned in their paper was that first and foremost, teachers need to know the perspectives of their learners. They need to know their diverse backgrounds, and they need to know what stage of training they're at, and be especially mindful of all of those nuances that can make people more sensitive to what they're experiencing. That definitely came up in our introductions, and hopefully that stands out in everybody's minds. The other piece of this, the second recommendation they made, was that you need to have this collaborative effort among faculty and students. And they specifically mentioned having expert outside observers coming into the program to be able to figure out what is going on that's beyond the overt curriculum, and how can we fix that if it needs to be fixed, or reinforce what is done well. So identifying and addressing those things. And again, I feel like this is kind of the premonition years ago. You all here as faculty and students, this mixed crowd, are here to hear about this and to hopefully then take this to the next places that you go for the next day and week and month and year to come, and to incorporate this more into your daily thought process. And then I'm not going to claim that I am an expert, but for sure Dr. Lopriato, Dr. Blaschke, and Dr. Hartzell coming in and getting to do some of these observations around the clinics and the wards, it really is, it's kind of this recommendation in action. Third, they said that all faculty should be willing to share the ethical dilemmas and the problems that they come across in their day-to-day work, not just the big things that stand out as a true ethical dilemma where anybody would recognize it, but the small things that happen in practice over time. And that there should also be an appreciation for ethical issues that is formally, overtly discussed at the organizational level. And they mentioned things like making sure, even at the application stage for medical schools, that you would, in your advertising materials, have a lot of material saying that you are focused on ethical issues, that you are making that a part of everyday life for the students as they come through this cultural process of learning how to be a medical professional. So then I wanted to end by just seeing if you all, thinking through what we've already discussed, where you're at, if you all have any ideas, they can be very general or very specific, but about how we can work through the issue of the hidden curriculum, how we can incorporate it into our daily practice. Yes?
One thing I feel like we put students in the clinical rotation, you know, in the third year, and we don't ever debrief with them, or we don't debrief enough with them about exactly what they are experiencing, you know, and how that, as compared to what they expected, et cetera. And I really think that should be built into the third year curriculum.
Okay, so a more formalized debriefing expectation with clerkship students especially. great. Any other thoughts? Again, they can be general. Yes.
I find it really hard because everybody has a different perspective. You could say one statement and 10 people will take it in 10 different ways. That makes it really hard.
Right. So especially in a larger group setting, right? So some of it, though, is still knowing your audience, knowing to whom you're speaking, and maybe you're not going to get information back until you get an evaluation, which could be weeks or months later, where you may get some hint that something that you mentioned that you thought was totally innocuous was offensive, or that didn't really fit with somebody's worldview or perspective. But you're right, it is an incredibly challenging situation, especially in a larger group setting.
But even in a small group, you could do the same statement to one student and you've gone through 10 sets of them and one finds them offensive and the other 9 are okay. So like you have no idea whether really it's the student or you who's the problem.
Okay, so be more, even in the small group, that you might have enough variety that it's just going to act against you in a sense. So what are ways that we can combat that? So maybe, again, just taking the time up front to kind of know our learners and having check-ins with them potentially, going back to the more frequent kind of check-in thought process of making sure that you have a little bit of one-on-one time with folks, that they do feel comfortable bringing things up to you. I think setting that culture, that kind of learning climate is incredibly important.
I'll just add a comment too. Two things come to my mind. One would be, I suspect there might be some devil's advocates, right? That sometimes, I certainly have faculty in my program that sort of play that role, to sort of be provocative and force thinking and things like that. But certainly when I do that, which is not as common as some of the people that I'm thinking of, when I personally do it, I sort of put a disclaimer in, that, I am going to be a little provocative. I do want to make you think. If I say something that offends you, come talk to me about it. It's probably not intentional. I don't think that necessarily works all the time. But I think it's one way to sort of turn some things that are hidden into more overt. And whether you're using it as a teaching tool or just in general. And then the second comment that I just wanted to bring up sort of relates to trauma-informed care. And I think that's probably incredibly important in camping and the population. In the 8 years or 4 times over 8 years observing people, you see a lot of social determinants of health. You see a lot of people that have been through a lot of things. Some of it historical, some of it cultural, some of it out of people's control. And I think just sort of having that awareness is important. And I think a lot of people sort of know it, but it's hard to live it sometimes too. Just food for thought.
So you're saying it numbs us because we see so much of that?
No. Don't get me wrong. I'm not saying in any way that anybody's doing anything wrong. I'm just thinking that even in my own hospital organization, I think across medicine we have a lot of work to do to improve people's compassion, understanding for, people aren't acting that way because of who they are, but probably because of things that have happened to them. And I've seen lots of good evidence of that in my trips of visiting here and observing. Occasionally I see some things that there's probably, it's balancing all the competing demands all at once in a lot of clinical situations. That we're all human and we miss it sometimes.
Great. Well, thank you all for your contributions. I'll throw up here just a few of the things that kind of came to mind as I was just writing some thoughts down, but really acknowledging the hidden curriculum, I think, is the first step, and making sure that we all know and talk about it, that it's there, that we know that the things that we learn as a culture are sometimes not necessarily overt. And then having a culture that's promoting transparency, trust, this openness to scrutiny that some of you hinted at. And then I was going to put a plug in for the Healer's Art, and when I looked on the medical school's website, I saw that every student does it in their first year here. And that okay.
That was the goal.
Okay.
And we tried that,
And now it's changed.
yeah.
Okay.
The problem was that it really, I think the students who really wanted to participate were, the having students there who really didn't want to be there really changed the tone.
Okay.
My hope would be that you would never admit a student who didn't want to be there, but that's a prejudice on my part. I would want that would be part of your admission criteria, that you thought that Healer's Art was an important course. But, so we've now gone to making it, but I can say that for this year's third year class, which is what, 86 or something? 81. So we have about 50 students did choose to take the Healer's Art. So that, kudos to the
Right.
class in general.
Right, and that is excellent, but I even wanted to put a plug in at the faculty, fellow, resident level if you have the opportunity. It's a course that focuses on personal values, professional values, and humanism, and kind of can help you to recenter and can get at a lot of the issues of just trying to hear people and to really listen to them and get to know them.
Because we're always in need of facilitators.
Yes,
We need the faculty to participate.
it's a rewarding experience. So I just wanted to close out with this quote that came down in a directive in some of our Department of Defense memos recently. So one of our leaders was putting forth this kind of ethos and our yearly mission plan about war fighting and our capabilities and improving that. But in the conclusion, he mentioned, remember, attitudes are caught from those who set the example. And I thought that couldn't be a better, more succinct way of kind of getting at this issue of the hidden curriculum, to just always be mindful of that. So we have just a minute or two. Are there any questions that you all have? And I'm happy to talk with anyone afterwards too, if you want. All right, then thank you all so much. I appreciate it.